Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we chat with Dr Louise Farrell, the head of colposcopy services at King Edward Memorial Hospital, about cervical screening tests. Dr Farrell is joined by Dr Olga Ward.
Louise, welcome to the podcast.
Thank you.
Louise, many years ago, we were doing pap smears and calling them pap smears. And the last couple of years, there's been a change. Most GPs are very aware of this, but could you just give us a bit of an overview of what changed and why?
Well, in December 2017, we changed from the pap smear to the cervical screening test, which is primary HPV testing with then a reflex liquid-based cytology on those that are HPV positive. And we have partial genotyping for type 16 and 18, which are the most risky HPV types. And the test covers 12 other types, so 14 types in all. We also changed the age range from 20 to 25 to 74. And the interval is now 5 yearly because we know that HPV testing, the negative predictive value of HPV testing is much greater than the negative predictive value of cytology alone. And so it allows for greater intervals because the protection lasts twice as long as a negative cytology test. And we've also got a national register, which means that all results throughout Australia are now on the same registry, and it has all the data on it, including the colposcopy data, which was not recorded previously. And the other big change is that we've gone to allowing women to self-collect, which is allowing them to collect samples themselves just for HPV DNA.
That sounds like we've made an enormous amount of progress. One of the things that many of my colleagues were concerned about was that just screening for HPV might not pick up precancerous lesions for other reasons. Is there any other reason that anyone would develop cervical cancer without HPV?
Most of the cervical cancers are HPV related, but not all, and some of the adenocarcinomas are not HPV related, but they constitute a small proportion of cancers. And we know that the old screening program missed cancers, and it's thought that this program will have a greater detection rate of precancerous abnormalities and will lower the rates of mortality from cervical cancer in Australia, which is already very low and one of the lowest in the world.
Fantastic. So it's been a really effective move. What sort of uptake has there been?
Well, we thought that because we were now moving to an invitation system rather than a reminder system, that there would be greater uptake. So far, the response to invitations, I think, has been slightly disappointing. They've looked at people who've been sent invitation letters, and they've shown that about 20% of women who receive an invitation letter go and have a cervical screening test within 6 months. So it's not a huge uptake, and there are varying rates of participation. Obviously, with a 5-year program, it's a little bit harder to work out the participation rate when you change from one program to another, but it still is reasonably low, not as high as we would like, and I think we hope that the invitation system would encourage more people to screen on time than the old system of reminding them when they were overdue. And of course the only way you got on the register previously was if you actually had a smear. So if you never had a smear, you didn't ever get on the registry. And so the underscreened women were not contacted. Now, using Medicare data, of course, we can contact never screened women.
That sounds good. Now, how do patients access this self-collect option?
Well, this has been, I think, the biggest disappointment of the program, because we thought that it would appeal to the under-screened and never-screened women, but the numbers have been incredibly disappointingly low. That's partly because when the program was introduced, there wasn't an available test. Since the program was introduced in December 2017, there have been some more data about self-collection. When we were setting up the program, we understood that self-collection was somewhat inferior in terms of pickup rates to health provider collected samples. But we now know that's not true, that they're very nearly equivalent.
So just run me through it. Is it a bit like a chlamydia self-collect? You use a PCR swab, not a brush?
Yes, that's
and we
correct.
could just give the patient...
Absolutely.
How do we then word it on the request form so that the patient gets a Medicare rebate?
If you just write CST on the form, and they will check on the registry whether they're eligible. So to be eligible currently, you have to be over 30 years of age, and you have to be more than 2 years overdue for your last cervical screening. Now that may change, and the government is looking at possibly expanding self-collection. Already self-collection has been expanded. Initially in the first iteration of the program, we said that pregnant women were not eligible. That's changed. Now pregnant women are eligible, and I think that's a very important development, because women access medical care during pregnancy who don't access medical care at any other time. So it's one time that you actually can access people who don't normally go to the doctor. And those women may well not want to have a speculum, and they may have anxiety about a speculum examination in pregnancy. They're often more uncomfortable in pregnancy. So self-collection for pregnant women was something that I felt very strongly about, as did some other people, and we've now had that change. So pregnant women are now able to have self-collection. So if they do the self-collection, currently in Western Australia, the only lab that will process a self-collected sample will be Pathwest.
So if we sent it to the local lab that actually picks up from our rural town, would they just send it on to Pathwest?
I think you'd have to clarify that with the lab. If you're doing a large volume, the only lab in Australia that's doing it at the moment is a private lab, is Sonic, and I think they're only doing it on the East Coast. VCS has been doing it. They were the first lab to have their test approved.
That's
Victorian Cytology Society, I think, and they will send you kits if you ask for them, and it's postage free, and they charge rebates, so you can actually, practitioners can directly access VCS, but Pathwest will send to them, and so you'd have to clarify whether the other labs would send on to VCS. Hopefully there will be commercially approved tests available soon, and all the labs will be able to offer self-collection. But I honestly believe improvement in the rates of self-collection is going to be the way we're going to make the biggest impact, because we know that in Australia about 3/4 of women who develop cervical cancer are under-screened or never screened. So they're the people we want to really attract to screening, and I think self-collection is the way of the future. And the fact that it's now been shown to be virtually equivalent to a health provider collected sample means that I think it is the way of the future. It does mean, of course, that those that are HPV positive will have to come back and have an LBC, which at current HPV rates will be about 9% of women. And, intuitively you might think, well, if they didn't want a speculum in the first place, why will they have one now? But all the studies show that a lot of women, one, they don't believe they have the virus, so and they don't really like the idea of the test, so they don't want the test. But if you say to them, I'm afraid you do have this virus, almost all women who are identified, well, at least 2/3 of them will then submit to a speculum examination, have an LBC without too much trouble.
Yeah, which sounds to me like a definite advance.
Yeah.
Although I have to say I use the cervical screening appointment for lots of other health screening at the same time, but I guess that's a separate issue. What happens if the patient presents with actual symptoms? So, you know, postcoital bleeding, or, you know, I stuck a tampon in there and I've got my cervix doesn't feel right, which we hear occasionally, or they're very uncomfortable, or...
Yeah, so symptoms, I mean, the only symptom that is really related to cervical cancer is postcoital bleeding. And postcoital bleeding isn't all that uncommon either. In young women, it's generally related to their contraception, and they're having breakthrough bleeding. As you know, 20% of people with implant do have breakthrough bleeding, and if they're having intercourse reasonably often, they're going. Some of it's going to be postcoital. So contraception is an important thing, and chlamydia is an important thing. I mean, we know that the commonest presenting symptom of chlamydia is postcoital bleeding. So in young women, a lot of them, you need to really consider whether they have an STI, because the chance of them having chlamydia is considerably greater than them having cervical cancer. Yeah. But postcoital bleeding is an indication for a co-test, and then needs to be investigated.
Yeah, so we would do a co-test and a set of swabs.
Yes.
And a bit more medical history. What about while we're actually looking at the cervix, if the cervix doesn't look quite right?
Yes. So the funny looking cervix is something that we get often in our colposcopy clinic. And without symptoms and with negative testing, we are yet to see anything that is pathological. And it's, you know, the cervix has a very wide and varied appearance. And we even get referrals from consultant gynecologists saying they think the cervix looks funny. And, you know, it's either a large Nabothian cyst, or recently it was a woman who had decidual reaction in pregnancy of her cervix, which can look quite alarming. But without symptoms and with negative testing, it's highly unlikely that the funny-looking cervix, unless it was a sort of fungating mass or something like that, would actually have any serious pathology within it. They're mostly Nabothian cysts or marked aversion of the glandular epithelium with a bit of inflammation.
Yeah. So if you were the GP and you're just kind of doing some routine testing and you look at the cervix and you think, whoa, that doesn't look quite right, what do you request a co-test immediately, and what do you put on the pathology form?
Well, I think if the woman doesn't have symptoms, I think, and she's negative HPV, I think it's pretty unlikely she's going to have anything. You can write abnormal looking cervix, and that does qualify for a co-test. But the rate of co-testing has been much higher than was originally predicted in the modelling. And I think that is one of the problems that we are seeing that has caused a bit of a blowout in the cost of the screening program and colposcopy referrals, because if you add co-testing, you add another test, which, you know, can add to the need for referral. And of course, the modelling was all based on co-testing only being for, you know, real symptoms of cervical cancer. So there's a lot of much higher rate of co-testing going on than basically the people who pay for the program would like.
Yes, I know the pathology companies are very conservative with their recommendations and quite frequently recommend colposcopic evaluation.
Yes.
Is is advised.
Yes.
Which is kind of good for my numbers, but not much good for the patients or the Medicare rebates.
Yes. Because colposcopy numbers have very much increased, far greater than the original modelling predicted. The original modelling predicted a rise of about 60% in the first 2 years, and the numbers have risen considerably more than that, particularly in public clinics, which is interesting. I'm not sure. The private numbers haven't gone up as much as the public clinic numbers have.
Well, how urgent is it to organise colposcopy? So if your patient does come back with HPV and what they usually say is possible LSIL.
Yeah. Well, one of the good things about cervical cancer, it does have quite a long lead-up period in the pre-invasive phase, and by detecting HPV, we're detecting the disease earlier in its progression than doing cytology. So we're measuring it at the point of infection when there's either minimal changes, cytological changes, or in the case of many women, none, because they're just repeatedly HPV positive. So in general terms, those women probably can wait a reasonable length of time. And I know the waiting lists for what we call our category 3 at King Edward, which is the non-16, 18 with either L-cell, query L-cell or negative cytology, so the persistent ones, is getting up there well over 6 months now, but that probably is quite safe.
Mm-hmm. That's very reassuring, particularly for country patients who find it difficult to access this kind of service. What sort of information does a colposcopist need on a referral letter if we are sending the patient on for reassessment?
Well, it's really important that we get the result, because otherwise we have to then chase them up, because you've got to write the referral result on the colposcopy form, and it's useful to include their past history. Obviously, symptoms are important because we will upgrade any referral where the woman is symptomatic. So if the woman has postcoital bleeding, it's very important to record that. The abnormal looking cervix, in our experience, without symptoms, has not been very rewarding in terms of finding disease, but that would be useful, I suppose, if you think the cervix looks abnormal. But in our experience at King Edward, we haven't found abnormal looking cervix in the absence of symptoms are very rewarding.
Yeah. Louise, some of the patients have been quite concerned about not being able to access rebated screening until they're 25, particularly when previously they were encouraged to access screening pretty much from the point of becoming sexually active. What's the rationale for that?
Well, there's very good evidence on the futility of screening under 25. There's no evidence that it actually changes the very low rate of cervical cancer. In 2003, the UK changed their screening age to 25, and nearby Wales kept theirs at 21 until 2013. And so there was 10 years where these two adjoining countries had separate commencement ages, and it was then shown that the stage of 1B cancers in women under 30 in the UK and Wales was exactly the same. So then Wales now have raised their age to 25 as well. And IARC, which is the International Agency for Research into Cancer, recommends that screening starts at 25 because there's no evidence that screening under 25 is effective. It's a different sort of cancer, I think, that has a much more rapid progression. It doesn't seem to be amenable to screening. But most importantly, since 2007 in Australia, we've been protecting young women against the two strains which are most likely to cause cervical cancer in young women, and that's 16 and 18. And so since 2007 we've had the vaccination program. So we're really protecting young women in Australia from early onset cervical cancer, and we also know that screening simply doesn't work. And the other problem about screening in this age group is there's very, very high rates of HPV carriage in this age group, and they will get changes that mimic high-grade disease but still regress, because viral replication can look very much like high-grade disease. And we know that you have to treat large numbers of women in this age group to prevent one cervical cancer. And so figures vary between having to treat between 300 and 900 young women under 25 to prevent one case of cervical cancer. And we do know that while treatment for precancerous lesions of the cervix is pretty safe, it is associated with some obstetric risks, and that is increasing your risk of preterm birth. So there is morbidity associated with treatment, and the reality is that for a lot of these women, they really don't need it.
So what about the young women who have had early onset of sexual intercourse? So these are the young women who start having sex at maybe 13 or 14, and quite frequently in that age group have multiple partners and often symptoms. Is that a different kind of category?
So in women who begin intercourse before 14 or commence intercourse before they are vaccinated, there is a provision for them to access a single HPV test before the age of 24. Now, obviously, people may feel concerned about being labelled with that. So on the form, if you write CST and then write eligible for HPV testing less than 24, the labs will honour that. The eligibility criteria are, of course, symptoms or having early onset intercourse before they were vaccinated, or obviously not vaccinated. So if they began having intercourse before 14 and either hadn't had their vaccination when they started or they have never been vaccinated, they are eligible for a test. So that doesn't discriminate between someone who has symptoms and who has early onset intercourse.
And that will be very useful. I know many of my patients are extremely sensitive about what pops up on their My Health record.
Yes.
Particularly if their parents can access their My Health record.
Yes.
Which is always extremely confronting for them. I notice on the request forms that the other thing they often ask about is the presence or absence of an intrauterine device. Does that change anything?
It does increase sometimes inflammatory changes, which are not a problem with the HPV test, so it won't alter the HPV test. But if the HPV test is positive and they have reflex liquid-based cytology, the inflammation that often is present with an IUD, the pathologist can explain if they know there's an IUD there.
Yep. Okay, so definitely put it in.
Yes, it's important.
Particularly if there's a co-test.
And also if they see actinomyces, they like to, if they think, oh, well, that's because there's an IUD there.
Yeah. I've had a couple of patients who've actually had cervical cancer treated and they've been sent back to me as their general practitioner for HPV screening, which might be of their cervical remnant or their vaginal vault. What happens when they still have a high-risk HPV coming back?
Well, then they remain at risk of recurrence and also of other HPV-related disease in the lower genital tract, and they do need increased surveillance. So I think that if they remain HPV positive after treatment, they do need to be evaluated by a specialist or someone who has expertise in looking at the lower genital tract with magnification such as the colposcope. People who have cervical cancer do clear the HPV like people who've been treated for high-grade disease. So
Yeah.
for some of them, they will clear the HPV.
And would there be any value at all in vaccinating those women sort of in later life with the Gardasil vaccine?
Well, sadly, there is no therapeutic action for the Gardasil or the new non-valent vaccine. There is a lot of work, though, being done on therapeutic vaccines, and there are lots of studies looking at substances which appear to clear the virus from the lower genital tract, trying to mount T-cell response to the virus. So I think that the next big breakthrough will be the therapeutic vaccines, and people like Ian Fraser, who developed the prophylactic vaccine, are working very hard on therapeutic vaccines. But there's trials going on all around the world looking at ways to stimulate clearance of the virus in those women who don't appear to be able to clear it. Jenny McCloskey is looking at running a trial soon, looking at trying to treat women who remain persistently virus positive. So there's a lot of work trying to look at ways of mounting the immune response in women who don't seem to be able to mount their own immune response. Because, of course, the normal human response is to mount an immune response to the virus, because most women clear the virus.
Yeah. And finally, Louise, could you talk a little bit about vaginal and vulval lesions, which, again, because we're screening the patients, we do occasionally see. What sort of specimens do you collect from it, and when do you get alarmed?
Well, so vaginal cancer is, of course, reasonably rare. There are only about 70 cases in Australia each year. But vaginal changes of vaginal intraepithelial neoplasia will be picked up on cytology and HPV testing. So for those women, we see them who come along and they've got an abnormal cervical screening test, but we can't find anything wrong with the cervix, and sometimes there's a lesion in the vagina. A lot of women who get vaginal cancer have had treatment in the past for a cervical lesion. So those women who have had cervical change in the past are required to keep screening until they become HPV negative. So the proof of cure screening regime after treatment should mean that those women are being followed up and will have LBC of their vaginal vault done, because if they remain virus positive. Mm-hmm. Vulval lesions are more common than vaginal lesions. Vulval cancer is more common in older women, but VIN is much more common in younger women, and that is HPV related. So it's very important, I think, in women who do have positive HPV to have a good look at the vulva. We know that vulval intraepithelial neoplasia is symptomatic in about 2/3 of women, the commonest symptom being itching or some kind of irritation or pain. But it still leaves about 1/3 of women who don't have any symptoms. But often there are lesions. Anything that's raised on the vulva should require close inspection. GPs are quite used to taking punch biopsies from the skin elsewhere, and to take a punch biopsy from the vulva is actually quite easy, and you just need a key punch, and they're very easy to take. So I think that pigmented lesions of the vulva, if they've got sharp borders or they're raised, obviously you need to worry about melanoma. But white lesion, VIN is commonly tends to be white. And I think if you're worried, you either can take a punch biopsy yourself or you can send them to someone else. But I think that the main problem I see with vulval lesions is people don't look, and
if you don't look, you won't find it.
You won't find it. So I think looking is very important. Vulval intraepithelial neoplasia is increasing throughout the world, and we're not really sure why. It might be related to HPV prevalence, but vulval intraepithelial neoplasia is strongly related to smoking. It's actually quite rare in non-smokers. Persuading people to give up smoking is not always an easy task.
No, but heck, if you find something precancerous on their vulva, perhaps that might be the little extra kick that the patients need.
Yes, perhaps.
Louise, do you have any final take-home messages for the GPs?
No, I just would like people to embrace, if we can, more self-collection. I think that I think has been, for me, one of the biggest disappointments of the program, that such tiny numbers have been done. And
so every time we notice an under-screened woman over 30, we can say, hey, listen, hun, you can do it this way.
Yes, and pregnant women too. Now that they've relaxed the thing on not being available for pregnant women, that has changed. And
so
I don't know.
Pregnant women still over 30?
Yep. And there is a committee looking into, changing the criteria for self-collection even more. So it may be that self-collection, the restrictions on self-collection may be further relaxed, and that's something that I look forward to, because I think that that's the way we're going to really change cervical cancer rates in Australia.
Louise, thanks so much for joining us today.
Thank you.